Hi, I'm Kim Stevens here at Fox 26. This is Diabetes Awareness Month, and diabetes is a disease that is affecting more and more people around our country, and even more and more people here in the Central Valley or the San Joaquin Valley of California. Yes, in part, it is lifestyle. Another part is just the way the body is reacting to changes going on, but we can do so many things about it. There is so much that we can do that is empowering, but it does take, in many cases, a change to one's life and a change to what was once considered to be normal. So I brought in a few people today to help us better understand and give us insight, into what diabetes type 1 and diabetes type 2 is, but also an endocrinologist who can help us also better understand what is going on in our bodies. Hopefully, this can empower an awful lot of people who are watching today. Dr. Babu is a doctor with UCSF. You've been an endocrinologist for quite some time, helping people in our area. So I appreciate you taking the time to be with us today, Dr. Babu. I also want people to know that this is becoming a little more of a personal interview than we normally do. Here is Kopi Sotiropulos, who has been living with type 2 diabetes for over 20 years. And then also my son Cooper, who was recently diagnosed with type 1 diabetes in his mid to early 20s. Thanks all of you for being with us today.
You're welcome.
Thank you.
Dr. Babu, you told me a little earlier in an interview that you're seeing an awful lot more people here in our area with either pre-diabetes or type 2. Why?
So, if you look at the prevalence of diabetes, it could be like some genetic definitely plays a factor to it. Then secondly, it's when there is more prevalence of obesity, your type 2 diabetes risk definitely increase. That's why when you really look at the data, if you break down the data of prevalence of diabetes, we see diabetes more in the non-metropolitan areas when compared to metropolitan areas. So I think it's more attributed to the lifestyle measures, like if you do more exercise, if you tend to eat more healthy, your prevalence of diabetes will be much way lower than if we don't do any or follow any of those lifestyle modifications.
Over 20 years ago, maybe 25 years ago, Kopi, you were diagnosed with type 2. What was that like? What were you feeling like that maybe led you to see the doctor?
Well, getting tired very easily, prime of my life, it's in the 50s, doing great, but just exhaustion, and had to get it checked out, and that's what we found. So it changed my life. Plus I was overweight, which was not obese, but to the point where it was enough to add to the problem that I didn't know I had. But we found all that out with exams and tests, and changed my whole life. I had to change my eating habits, started exercising, getting walking, just getting out, and not just going home and just, man, I'm tired, type of thing. So it just kind of changed my lifestyle. And
how did you feel, though, when you got that diagnosis?
I said, could I be in a commercial? No, just kidding. It's like, what? I've got diabetes. I eat good food. Yeah, good Greek food. Yeah, which is, has a lot of olive oil, and you got some lamb fat, and you got all that stuff that is delicious, but not all that good for a lot of people. Within, you can be careful and watch the amount you eat, but if you overdo it, which is what I was doing because it was there every day. So I had to change my diet. I got into exercising, walking, not so much weightlifting, but just walking, keeping the blood going, burning the calories. Mm-hmm. And I was about 20 pounds overweight, almost 25. So I lost weight, And it took time. It didn't happen overnight, but we got to it. And I was weighing, 180, almost 200 pounds there for a while. I'm down to my mid 160s, like 164, 165. Sometimes I get a little lower if I behave a little better, but it's helped quite a bit. So I've been able to manage it. I'm only taking metformin, one pill every once a day. I got rid of all the other diabetic pills. There was another one, but the doctor said about 6 months ago, just your metformin once a day and you're fine. Just keep up what you're doing. So it paid off. So I'm controlling it, and I feel much better. I do walking. I'm more active, and I watch what I eat.
Dr. Babu, you're shaking your head. So what he's saying to you make you feel as an endocrinologist?
I mean, I should say Kopi did awesome. So your lifestyle changes basically controlled your diabetes, not just for 2 years, 3 years. You're talking 20 years here.
Yeah.
Right.
And the thing is, I asked my doctor, great, when can I get off the medicine? He says, oh, yeah, you're not going to get off it. You're going to keep taking metformin and have some with you when you head out of town.
Yeah. So that's why, like I said, the duration of the diabetes also plays an important role. So if you have it for longer time, it's like slightly difficult to completely off of the medication, but you can just control it with just one pill and lifestyle, and then we can do a better job preventing all the complications related to diabetes, like stroke, heart attack, all those we are talking about. Yes.
Correct.
Okay. Now, Cooper, you were diagnosed about 1.5 years ago with type 1 diabetes. You were not a child, you were an adult. It's long been called childhood diabetes. How were you feeling that led you to get diagnosed?
I felt lethargic all the time, and the way I was going about life, I just thought I was tired or maybe needed to eat a little better or something. But it came to a point where I lost 20 pounds in a span of 3 weeks. And at that point, I went on the scale and I knew something was wrong. So at that point, I went to the doctor. They ordered some blood tests, and then within a couple hours, I was told to go to the ER. So it all happened very, very fast. But it started with just the feeling lethargic, having to take naps, and just feeling either really tired and just weak, or after a workout feeling like I'm going to pass out, to then losing that 20 pounds and then having to really kickstart into that diagnosis.
Mm-hmm. Dr. Babu, I see you shaking your head on this too. So tell me how you're feeling about this diagnosis.
Yeah, so most of the time, type 1 diabetes, as Cooper mentioned, it's comes just out of the blue, right? Patients are not prepared, and most of the time it's either a very young patient. I have patients who are in their 30s and 40s, went through the same symptoms like Cooper did. As I said, we call it LADA, late onset, latent autoimmune diabetes. That's what we call it. So I feel like it's a little bit difficult for those set of my patients to accept that diagnosis is one of the things which I see the most. And it can, most of the time, my patients actually develop a very complication out of this called diabetic ketoacidosis. That is when you don't have insulin. Basically, you start having acid buildup in our system because our fat cells start breaking in. And then we have a lot of acid in our system, and then it is very life-threatening. And so most of the time with LADA, what we see is if they are not reaching to the physicians at an adequate time, they can develop with diabetic ketoacidosis and they end up in the hospital. And there has been instances where people didn't know that they have type 1, and then they actually passed out, and then they had severe diabetic ketotic coma, and then they had severe complications neurologically. So it's very deadly if we don't diagnose it on time.
I didn't know the name of that. But that's exactly what I was worried about when Cooper called and said, they say I need to go to the ER, but I could go, maybe tomorrow, go home and then sleep and then go tomorrow. And I was thinking of that, I'm like, go. And thankfully, you were in the ER and you were taken care of. But your life has changed dramatically, Cooper. So what did you do day one once you came out of the ER and you had type 1 diabetes?
Day one, I think the most important part was just tracking what my blood sugar levels were. Because when I got to the ER, my levels were in the mid 500s. So close to that level of diabetic coma. At least that's what I was told when I went to the ER. So from the minute I was discharged from the ER, I was told to manage through observation, treat it like a science experiment. Always track your levels, record it, and see what the trends were. Luckily for me, after a couple weeks or maybe a month of pricking my fingers, you see in all the commercials, I was lucky enough to get a continuous glucose monitor, which it's in my arm. It tracks my blood sugar continuously throughout the day, and so that was the biggest thing, was just tracking what my blood sugar levels were at, and then from there, acting, whether it's too high or too low, doing something to adjust.
So now you have to carry around a bag of insulin.
Yeah, I do. Figured carry around kind of a cool bag, try to make it a little stylish, but yeah, I do have to carry around insulin because every meal I have to inject a certain amount of insulin. I'm working on a ratio of carbs to insulin. And so, yeah, every meal, and then once before bed, the one before bed is a long acting, and then every meal, that's a short acting insulin that I use.
But Kopi, you don't have to use insulin, right?
No, I don't. No.
So is that common then, Dr. Babu? Is that one type you need to add more insulin and the other one you don't?
So there are some type 2 diabetic patients as they progress, like if they don't take care of their diabetes, just like the way Kopi did, right? They can progress and they can have the beta cells fail, and then they can become insulin dependent eventually. So with Cooper, he has type 1 diabetes. So as I mentioned, in my interview with you before, so our pancreas has beta cells and alpha cells. The beta cells produce the insulin. So typically what happens in type 1 diabetes is our body develops the antibodies which will destroy those beta cells. Okay, so it's kind of like, our body is fighting against our own organ, It's an autoimmunity. So because the beta cells gets destroyed, there is no insulin production. And so that is why the type 1 diabetics, most of the time, they are insulin dependent because there is no insulin production from the pancreas. And as Kopi mentioned, he's on 2 types of insulin. So when we talk about it, it's the long-acting, which is the 24-hour. We call it the basal insulin, which is for 24 hours. And then it's usually taken once a day. And then we do the mealtime insulin, which is the short or the fast-acting insulins, because the fast-acting insulin is out of your system in 3 to 4 hours. Okay, and that is why we take it 3 times a day before breakfast, lunch, and dinner. And then the basal insulin is out of our system in 24 hours. And so that is why we take it once a day. Now, with the advancement of technology, I'm glad that Cooper mentioned that, so one of the things we advocate as every endocrinologist advocate is for our type 1 diabetics, especially to be on an insulin pump with the sensor. So like as Cooper mentioned, there are different kinds of sensors out in the market. Like we have Freestyle Libre 3, we have Freestyle Libre 2, we have the Dexcom sensor. But the beauty is most of these sensors can actually communicate with the insulin pumps. And so it's almost like could we call it the closed loop system? Mm-hmm. So the sensor will communicate with the pump, and the insulin pump, what we do for our patients is like we program, but we only use one kind of insulin, which is the fast-acting insulin, which we use it as a basal and when you eat, you enter the grams of carbs into the pump, and the pump will calculate the dose for the patients. Yeah, it's very neat that way. So you don't have to take shots all the time. So you just enter the amount of carbohydrates, and the pump will give the insulin for that meal. And on top of that, the pump is also giving you the small dose of insulin 24/7. And with the latest technology, as I mentioned, the sensor is communicating, the continuous glucose monitoring is communicating with the pump. So based on the blood sugar level, the pump can adjust the rate of the insulin too. Okay, so one of the things I advocate for my patients is to be on an insulin pump therapy, which will make a big difference in their life, actually.
Okay, well, that's helpful. Clearly, it looks like this medicine is needed and certainly not something you can just take for a month and then stop. This is needed medicine, lifelong. So have you, Kopi, or you, Cooper, had any issues with insurance in making sure that you get your medicine as you need? And then Dr. Babu, I'd like to know if you've had any concerns with that with patients as well. We'll start with you, Kopi.
I have not had any problems whatsoever. I get my prescription, the metformin. It's right there on the table. Come get it. Go home, take your medicine, and stay healthy. No problem whatsoever. It's been easy.
What about you, Cooper?
For me, the insulin has been same story as Kopi, relatively easy to do. The only issue would be with my Dexcom monitor, because it's through my insurance, but it's also through a third-party supplier. And sometimes there's just miscommunications between the insurance company and the third-party supplier that have led to some headaches and some delays in shipments. So I'll go sometimes a couple weeks at a time having to just go back to pricking my finger, which I know before these CGMs, continuous glucose monitors, were available, that was just daily life for diabetics. So it's not the biggest deal for me, but it is a lot easier when I can have this Dexcom, the CGM in my arm, able to track my blood sugar levels.
Dr. Babu?
Yeah, so getting insulin, for the most patients, they do. Most of the commercial insurances, it's pretty easy. And then if you talk about not just insulin, any diabetic medications, if they have commercial insurance, most of the time, most of the medications are covered. Some of the medications are generic. For example, Kopi mentioned that you are on metformin, but it's been there since 1992, 1995 in the market. So it's very generic. And so it's very cheaper. So it also depends if the medication is generic too, So one of the struggles which I have seen in my patients is the medication and insulin is covered, but it's the copay they are not able to afford. For example, the sensor is covered, Dr. Babu, but my copay is I think my camera is a little bit in and out, $400 or $300, which I cannot afford, right? So, and then there are some patients without no insurance, okay? In Central Valley, we see this a lot. We have a lot of patients who are uninsured, and then they don't have any insurance, and then their blood sugars are in the 600s. They can also, when they are underserved population, can also have the same thing, right? Type 2 and type 1 diabetes developed. So what we do for those patients when they struggle with higher copay for insulin, or when they struggle with having no insurances, Walmart actually does have insulin, 1,000 units of insulin sold for $25.
Wow.
Okay. So basically it's letting the primary care physicians, ER physicians, urgent care aware of the fact that when you have a patient who is underserved, they don't have any insurance, or if the copay for some of my patients is very, very high, they cannot afford. I have a lot of Medicare patients with higher copay, or when they go into this donut hole, where they cannot afford insulin. I ask them, hey, go to the Walmart, get this insulin so we can get the NPH insulin, which is an old insulin, but it still works as a basal. And then we just have to, the mechanics is slightly different, the way it acts. So we have to use it twice a day instead of once a day, when we talk about the long acting. And then there is regular insulin we use as with the meals. And then there is a mixed insulin where the basal and the fast acting and the long acting is combined. We call it the 70/30. So these three type of insulin is available at Walmart for $25. 1,000 units you will get that way. So what I do is I ask my patients to go there, get this insulin, and then try to use metformin, Actos, those medications which are already generic, so that the patients can control their diabetes better.
Oh, wow.
It's just having that awareness. Most of the time, our patients are getting insulin, don't get me wrong, but I come across these circumstances where I have to send them to Walmart to get the insulin, and then you basically do it as cash pay.
Okay. All right. I'd like to ask Kopi and Cooper if you have any questions of Dr. Babu. You only get to see your endocrinologist every once in a while, so you've got one right here. Kopi, do you have anything you'd like to ask or anything you'd like to know?
Not that much. I've survived so far, so I've been pretty lucky with the help of our doctor, of course, and trying to stay with the program. Sleep is very important. Sleep. I try to get to bed. I try to get 7 hours at least every night, if not more. But unfortunately, the cat every now and then wants to go out. So, you got to wake up and get the cat out of there.
You're also on a morning show where your wake-up call is early.
Not like it used to be at 2 o'clock in the morning. But
that's true.
My shorter shift, which has helped quite a bit. So, but sleep is really important. And I always try to take a nap. That makes sense to me in the afternoon when I get home. I get home a little earlier, but after I change the roof on the house and paint the interior every day. Just kidding. So I try to get enough sleep. That really helps a lot.
You've noticed that, Dr. Babu, that sleep really does play a part in health with this?
Definitely. Because sleep is very important for us, which one of the problems in the Valley and everywhere in the Western population, which I see, is the sleep deprivation, right? The problem is when we don't sleep well. So a lot of women complain to me, oh, Dr. Babu, I'm doing everything, but I am fatigued. I'm not able to lose weight. I'm doing everything right, which I do trust them. They are doing everything right. But when you really take a sleep history, oh, I'm not sleeping. I'm waking up multiple times. I am sleeping maybe 3-4 hours a day. So when you have less sleep, what can happen is our stress hormones go high. For example, one of the stress hormones is cortisol. And then cortisol is a hormone which will increase when you are stressed, when you are not sleeping, when your body is not getting rested well. Physiologically, our stress levels are higher. So this cortisol levels go high. And when the cortisol levels go high, your blood sugar will be high. You will never lose weight. You are tired all the time. And then also there is another entity called sleep apnea, which we see a lot in the Valley too, because when you have overweight patients, they can have sleep apnea. And if you have undiagnosed sleep apnea, that can also cause a lot of health-related consequences.
Wow. So many things are intertied or interwoven with each other. Crazy. Cooper, do you have any questions of Dr. Babu?
I think one, yeah. I understand that to maintain your diabetes and to maintain a healthy A1C, you need to manage your, like Kopi said, your sleep, but also your diet and exercise. I know that a healthy life has to be surrounded by a combination of all those, but in your opinion, what's more important? Is it the diet or is it the exercise for both a type 1 diabetic and possibly for a type 2 diabetic as well?
I would say, to me, I'm a big advocate of a good diet. And I mentioned in my interview before, I never tell my patients, stop eating this, stop eating that, go on a keto, never. As a type 1, I always say never go on a keto diet because it actually can cause more acid buildup. So it can harm you, right? So then to me, it's the portion control and the diet. And if you even look at the data, right? Yes, we need exercise. I'm not saying not to exercise, don't get me wrong. But my point is, when you just exercise, the amount of weight you lose when compared to when you go on a good diet, the diet will make you lose more weight than the exercise. So that is why I always say to my patients, do it together, right? To me, if I stress a little bit more important, so if you ask me, Dr. Babu, what will you choose, right? Is it diet or to ask, to what Cooper asked me, to answer what Cooper asked me, I would say I would just focus on the diet first, because I personally feel like when we do the diet right, the blood sugar starts getting better. We start losing some weight, especially in type 2, not type 1. But all these will basically reset our system, right? And then patients will start feeling better, and then automatically you will start exercising and back to normal and being more active. So I would say a good diet, meeting with a dietitian, and as you mentioned, Cooper, um, uh, counting carbs right now, right? Just to get into that focus. So you can just basically target. So usually what we do for type 1s is I will tell them, okay, so you take 1 unit for every 10 grams of carbs. So they're counting. So meeting with the dietitian is also very important. And it's a lot of, it's great. It takes time to learn that process. And then I have to mention one more thing. So technology is advancing, medicines are advancing. So as you know, I don't know whether you saw that article in New York Times. We just had our patient 2 years ago who had the stem cell transplantation with beta cells. And he's a type 1 diabetic, and he's been insulin free for the last 1 year. So he was on insulin. So he actually did the stem cells. We are developing the beta cells, and this beta cells, we actually do this transplantation. So we cannot transplant it into the pancreas. What we do is basically we go through the hepatic vein and we transplant it into the liver sinusoids. That's how we that system work. It's not perfect, but at least the first or a stem cell transplant patient, it was a big article in New York Times. I think 2023 or 2022. I cannot remember the exact date. He's still insulin free for the last 1 year. So there is a lot coming. And I know UCSF San Francisco campus have lots of research going on. And I don't know whether you know about this, Cooper, but the new onset diabetic patients, there is a injection now. We call it the checkpoint inhibitors, or these are antibody inhibitors, which is being on trials. And even though some patients were still on insulin, the new onset type 1s with this medication, but what we found that the blood sugar fluctuations was much less. So there is a lot of advancement coming up. So hopefully, we will come to that point where we can do a better job with our diabetic patients.
That's really reassuring and hopeful. Thank you.
And then also, all my treatments, I recommend to use the sensor, continuous glucose monitoring, and even for type 2 diabetic patients.
Okay. It's often said when people are diagnosed with something that it is, at first it feels like a curse. And then people say, oh my gosh, it's actually turned out to be a blessing, whether it was a wake-up call for changing a lifestyle, or whether the knowledge that you've gained because it was forced upon you is helping others. Kopi, have you noticed that through the years, have people come to you and said, hey, I know that you're living with type 2. Can you give me some advice? I mean, of course, knowing you're not a doctor, but still, when you can talk with someone who's on that road or been through it, sometimes it it can be helpful. Have you been in any experiences like that?
Yeah, on occasion, not every day, but on occasion, people come up, friends, and even people that watch the show every now and then if I'm out and about, and we'll talk about it. And I say, well, this is what happened to me, and find out where they are in their analysis and understanding of what's going on. And I just tell them what I've done, and that thank God it's helped. We still are diabetic, but it's helped. We're able to control it, not destroying our bodies, and be around for a lot longer to dance at our grandchildren's weddings. You know what I mean? It's what it's
Right.
about. So I enjoy doing that, and it does. I'm not saving people, but I'm helping every now and then when I can. Yeah,
Yeah.
it's good.
Cooper, what about you?
I think initially I was lucky enough to have a family friend who had a similar situation. I think he was maybe 28 when he got diagnosed. He's now in his 50s. And so he was a great help initially, and I mean ongoing. But now that I've had it for over a year and a half, I also know somebody who is near my age who got diagnosed with type 1. And if he's ever dealing with anything, and he actually had a little emergency with some insulin, and he called me after he called his doctors. And like Kopi said, I acknowledge that I'm obviously not a doctor, but I have this experience, and if this experience could help anyone else, I'd love to share, because it can be intimidating when it's just you and a doctor in a room, and you don't really know what a personal experience is like. You know what you should be doing on paper, but maybe not what it's like for somebody to actually go through it. So I think that's been a big part for me in terms of helping a buddy of mine, and also just general knowledge. I had no idea about diabetes before I was diagnosed, but now my immediate circle of friends and family, we all are very knowledgeable of it, and grateful for that.
Thank you for sharing that. All right, Dr. Babu, I leave the final word to you about, after all we've heard these stories, we've learned a little bit more about type 1 and type 2 diabetes. What do you say to the viewers out there to try to help us, if at all possible, prevent it or live
Yes.
with it?
Yes. So one of the things I always, I take Central Valley as our community, right? So the health of our community is very important. So one thing I always tell is, like, be aware about this disease, because it's very prevalent in our area in Central Valley. So be aware of the symptoms. Like, if you have anyone in your family or with yourself going through these symptoms, get help. And then I know it's easier said than done. Like, why me? Rather than asking that questions, accepting it, and then try to take care of our health is very, very important, because a lot of the times in the early stages, with the good lifestyle changes, we can prevent or we can actually prevent the progression of especially type 2 diabetes in a better way. And if it's a type 1 diabetic, we know that we have a lot of technology advancement, being on a continuous glucose monitoring sensor, being on an insulin pump, and then knowing about the newer medications in the market. That's also very important for our patients. And I totally understand what Cooper said. Like, when you are with a physician, yes, regular physician appointments, everything is important. We need to check our labs and stuff. But most of the physicians don't live with the disease. So I do have a respect for my patients when they tell me, because, yeah, I do hear them, but do I understand the gravity? That's always. So always, that's there. So I am a big advocate of this diabetes support groups. Okay. So being in those support groups is really helpful. And so my advice is just be aware. And then we also need to target the pre-diabetic population. Anyone is hearing this, if they have pre-diabetes, remember that trial I talked to you. 30 minutes, 5 times a day of just brisk walking and lifestyle modification, they did not progress to type 2 diabetes. So if we catch it early on, we can try to prevent all these complications too. So that's my message.
And it's a wonderful one. Thank you so much. Cooper, Kopi, Dr. Babu, I appreciate your time today. Thank you.
You're welcome.
Welcome.